Welcome to Healthcare De Jure, where we dish up and digest the latest in healthcare. For the next 30 minutes, sit back as we bring you insight, commentary, and discussion on trending topics to the table, all expertly served up by our host and his guests. Healthcare De Jure is brought to you by High Tech Answers and HealthcareNOWradio, part of the Health IT Answers Network. The broadcast is sponsored by the law offices of Myrick O'Connell. And now here is your host, Matt Fisher.
Welcome back, and thank you for joining as we dive into the hottest topics in healthcare. I'm your host, Matt Fisher. On the menu today is Mandi Bishop, co-founder of Aloha Health and an overall healthcare firebrand. It's great to have you on today, Mandi.
Thanks so much, Matt. I'm really excited to be joining you. I really appreciate you having me on.
Yeah, no, it's great. It's always great to connect with a fellow HIMSS social media ambassador, both past and present, because I believe we'll both be on the ticket for the upcoming 2017 annual conference.
Absolutely. I'm really excited. I was one of the founding members of the HIMSS Social Media Ambassador class, and I'm just thrilled at the way that that program has grown and expanded and the value that I think it brings both to the HIMSS organization as well as kind of to the broader healthcare community.
Yeah, no, I agree. It has contributed a lot of value and helped to start a lot of conversations. But before we get too much into our conversation, do you want to give everyone a brief introduction as to who you are and what you do, and for those not lucky enough to know you yet?
Sure. So as you mentioned, I'm the co-founder of an organization called Aloha Health that exists to make life actionable for healthcare, and we're going to talk a little bit about that today and what that means. I serve on the advisory board of an organization called the Society for Participatory Medicine. So this is a society that drives the relationship between patients and providers as a partnership and advocates for collaborative care delivery. I am on the advisory board for an organization called STEM Princess, which exists to encourage women and girls to pursue career opportunities in STEM fields. I am a contributor to the American Journal of Accountable Care and to Tincture, and I am a steering committee member for Health Data Palooza, an organization and an event that I'm really passionate about. And I'm also the mom to a newly minted learner's permit driver and a recent military wife. So lots of things.
Yeah, that is a lot of things to keep track of. I'm amazed that you were able to carve out the time to talk with me today, given how much I know that you're traveling around just by seeing all the different conferences and activities you're engaged in through Twitter.
Yeah, and that's another thing I do. I love to tweet, right? That's become part and parcel of who I am, and it's a big portion of the reason why I'm here.
Yeah, no, I agree. It's I think it's opened a lot of doors too. It's you get to meet. I don't think we would have had the chance to meet any other way. It's
no.
Yeah, because you end up in your different kind of little, for lack of a better say, we end up in our silos, and then things like Twitter have allowed those to be broken down and really create new opportunities.
Absolutely, it really has leveled the playing field and allowed us to kind of have peer-to-peer contact relationships with people who are completely outside of the realm of our normal day-to-day experience. So things, I don't know that I ever would have gotten as involved in healthcare policy, for example, had it not been for Twitter and understanding what happens in the policy landscape and understanding the challenges that the regulatory bodies have and understanding kind of the O&C processes and all the opportunities and the challenges that they're facing. It gets all of that happened because of Twitter. So I joke all the time about Twitter and about the fact that, my life happens 140 characters at a time. My professional life does anyway. But it's so true. That's how I get my news. It's the first place I go in the morning to see what's happening in our little world. And it's definitely where I've met a lot of really tremendous people and had an opportunity to collaborate with a lot of really fine minds, such as yourself. So.
Yep. Well, kind of your reference into that helped break you into the policy area. Having been interacting with you, it seems like one of the biggest areas of policy and just overall healthcare that you've been diving into are the social determinants of health, which I've noticed, it has increased exponentially, probably within this past year and even less than a year of the, kind of that social discourse. So, how do you see that happened, and then maybe provide an introduction to what is meant by social determinants of health?
Sure. So social determinants of health, when I'm speaking about it, I think about it very broadly. So social determinants are the things that happen outside of your clinical experience. So if you think about your encounter and you think about the information that you would give to your doctor when you go to see your doctor, they're going to know things like your height, your weight. They're going to know your marital status. They'll know the last, if you're a woman, they'll know, the last menstrual cycle that you had. They'll know whether or not you had a baby and at what date you had the baby and was the baby at normal birth weight. They'll know things like your blood pressure, your glucose, but they're not necessarily going to know if your father just died. They're not necessarily going to know if you have a newly minted teenage daughter who's driving your stress level through the roof. So things like if I go to see my doctor right now and my doctor tells me that I've gained, we were just talking before the show that I've gained 10 pounds recently, and my blood pressure is likely through the roof, and my stressors, there are a number of indicators that might point to me being pre-hypertensive or hypertensive, right? So potentially moving towards diabetes, moving down the pre-diabetic spectrum. But if you understand the life context and you understand that I had surgery which substantially reduced my ability to exercise over a period of time, and that I had been a very competitive athlete prior to that point, I had been a CrossFitter and had been a marathon runner prior to that. If you understood a lot about the life context and knew that my daughter had just gotten her driver's license and knew that these other things were happening in my life that might, form a perfect storm of sorts that would, drive up my stress level, that would increase my blood pressure, that would decrease the more healthy stress outlets that I have as far as exercise and other things. If you understood that life context, you might think about the clinical outcomes that you're seeing and the results of my, clinical encounter data a little bit differently. So we think about social determinants as things that are environmental, social, financial, all of those other dimensions of life that really comprise the 95% of the variables that impact both your health and your outcomes, as well as your ability to manage your health effectively. So, we like to use this very simple example of diabetes. If you're an insulin-dependent diabetic who doesn't have access to a refrigerator, then how are you going, what other care alternatives do you have? But if your doctor doesn't know that you don't have access to a refrigerator, then they're not necessarily able to deviate that care plan. So that's just a very simple example of how to think about the importance of life context when we're thinking about health and how to influence and improve and help educate others on how to manage their health effectively.
So, that's a very, as you kind of prefaced it, it's a very wide spectrum of issues. How are tools helping to get that information into the hands of clinicians and providers, or what do you see needs to happen to be able to help get that type of information more into the hands of the healthcare provider?
So it is definitely becoming, you've seen, like you mentioned, over the last year or so, social determinants of health has entered the discourse. It's entered the mainstream discourse for the healthcare industry to start talking about these data points as being important and understanding that a substantial portion of the factors that influence health, and then the people in our industry really care about dollars, right? So it influences not just health, but it influences your revenue stream, it influences your population health management opportunities, right? So if you have a diabetic population, I actually was just reading recently that only 14% of the diabetes patients are 100% compliant with the care plans that they are prescribed. And that means, care plans, not just their medication, and medication is both the adherence and the persistence, but then the lifestyle, right? So are they not smoking? Are they avoiding the foods that they're told to avoid? Are they adhering and persisting with their medications? But only 14% of patients are 100% compliant with those recommendations. And that's a really low number. And the problem with the industry is that we don't ever ask why. So collectively, we understand that these problems exist, but we're beating our patients with a stick and just telling them, like, it's very much like parents punishing children, saying, like, you will do this, you will clean your room, and we're not, we're giving them an or else, like, you will clean your room or else we'll kick you out of this program and you won't be eligible for these incentives or whatever, but we're not taking the opportunity to understand why they may not understand the things that are being asked of them, or why there might be challenges or barriers to them being able to comply or adhere with the recommendations that are provided. Healthcare as an industry is starting to notice that these things matter, and starting to notice that these things may matter much more than the clinical prescriptions, like may matter much more than the clinical care pathways. So being able to understand motivations, challenges, and barriers for healthier outcomes is the wave of the future. And so there's a lot of new policy initiatives that are focusing on this. There's like the Public Health 3.0 framework is a new initiative that HHS has put forth that's encouraging kind of regional collaboratives to work with public health and community health to identify areas of opportunity to improve the health of a region, and to improve it not just within the clinical setting, but to work together with community services that are available to address public health initiatives, and then to improve the overall health and well-being of an entire area. So those types of initiatives are happening. They're starting to bubble up and become more and more mainstream. They're starting to surface in kind of congressional. There's actually a congressional briefing on social determinants of health on Monday. So it's starting to to pick up steam, but it is not yet tied. It's tough to tie it directly to things like population health initiatives, things like capitated contract arrangements, ACOs, in order to make the leap to make these things actionable at point of care, to make them actionable for care management or disease management program for an insurer. You as an organization, as an innovator, and this is what Aloha does, you have to be able to tie them to their specific programs that matter for reimbursement and be able to show that there is a return on investment in identifying ways to leverage this type of information in deviations in care pathways and engagement opportunities.
Yeah, no, I think that definitely makes sense. I think one of the first things you said as you were leaning into that description was, money will be a driver, and yeah. I definitely agree with you. It seems like the conversation around the social determinants has increased as the discussion around overall value-based care has accelerated. And I certainly see it with one of my clients that has a lot more case managers now, because this client has gone very far down the road of risk-based contracting, so that they're full risk for the majority of their patients, so they need to make sure that they're getting a fuller picture, they're interacting with people more.
Right. Right, absolutely, and that's where that's where the kind of the low-hanging fruit would be in this area, or the area to have the biggest opportunity to recognize the effectiveness of these types of programs is in working with the risk-based contracting mechanisms, because there is a financial stake in the ground, and they have to be able to have results, and what we have been doing has not been working, right? So healthcare costs and healthcare pricing have done nothing but increase, and not just increase, but increase exponentially year over year. So what we have been doing is not working, and so clearly continuing to do the business of medicine and the business of healthcare the way that it has always been done is not effective. And so being able to understand, all of these other elements that are happening outside of the traditional healthcare delivery system, to see how those factors might be able to be leveraged to influence outcomes, and to be able to influence, the financial and the health trajectories of your organization, it's going to be key to survival. And we'll see it happen first in those risk-based contracting mechanisms, because they have the most at stake. But I think as more and more of those entities begin to see success, we will start to see the social determinants of health pick up steam and become, I believe within a decade we will begin to see the blurring between public health and healthcare, commercial healthcare begin to, that'll begin to blend more and more. And we'll see the social determinants becoming just a part of your, a part of your healthcare experience, is that they will understand more about you and start to see you as a person, not just as a specific condition patient.
Right.
Yeah.
So another piece I wanted to tease out there, and you mentioned it, was that, oftentimes a patient is treated with, as you said, a stick, saying, do this or else.
Yes.
Do we need to introduce a carrot to provide some type of incentive, or kind of what paradigm shift would you like to see on that front?
Yeah, but I think that the problem is because healthcare has a one-size-fits-all problem, right? So it's very difficult for us to allow for personalization and allow for an understanding and application at scale of different motivations for different people. So like what motivates me to eat healthy and to go to the gym is not going to be the same thing that motivates my husband, is not necessarily going to be, certainly not going to be the same thing that motivates my teenage daughter. So understanding that each one of us has a different kind of carrot that would be needed in order for us to really effectively engage. I think that there are individuals in healthcare system organizations that understand that that is true, but being able to effectively deploy that level of personalization is something that they're struggling with. And we're struggling with the foundational basics right now, right? We're still passing around medical records on paper. So until we get beyond the paradigm of being able to share data with each other and pass medical records on paper, it can be challenging for organizations, let alone an individual doctor, to understand that there are ways they could take a data-driven approach to personalizing a care pathway and personalizing an engagement so that you can recognize that carrot. Like, what is the carrot going to be for Matt Fisher, and what is the carrot going to be for Mandi Bishop? And, is it a financial incentive? Is it an emotional incentive? Is it, heck, is it dog sitting? It's some, what's going to be the area of opportunity that I'm most likely to respond to that's going to help me learn to better manage my own care and help me get excited about educating myself and wanting to learn more. Like, do I know enough? Do I have enough, health literacy and literacy in general to be able to effectively communicate and understand what I need to do? So anyway, that level of personalization, I think, is a big barrier to being able to adequately apply a carrot. So right now, all we have are sticks because we don't understand how to effectively apply an individual carrot.
Yeah, and I wonder if it's also a combination of, one, as you said, not understanding, but also the constraints of the system. Because my wife is a physician, primary care, and she went from an organization. She was at the client that I mentioned who said they have a lot of risk-based, where the promise or the initial thought of the promise was, we do this, you'll have more time with your patients because we don't need to churn to generate revenue. But it turned out that while they didn't have to churn, they also had to increase their panel size because they wanted more patients on the panel to create more per member per month payments. So it still ended up needing to see a lot of patients. So it seems like, as you've been suggesting very readily, that there are a lot of factors that need to change. And I think we're going through a period where the entire fundamental structure of how healthcare is performed and delivered is being shifted, and you've got a lot of different stakeholders who are fighting to go in different directions.
Yeah, you really do. It's interesting, again, recently researching all of the areas of opportunity to help address and align these types of social determinant data programs to the clinician's workflow, and like you said, the clinicians already have enough on their plate. It is very, very challenging. Like, we don't want to introduce another data point to them that's not meaningful. You don't want to introduce anything that's going to detract from the 7 minutes, 7 minutes per patient encounter that they already have, right? So 7 minutes, like, what is it possible for you to understand in 7 minutes? It's not very specifically what's necessary to meet all of the quality metrics that you have to fill out, like every single one of those boxes that you have to check. In researching on diabetes, I realized that there are 148 diabetes quality measures. Between ARC and all of the other organizations that participate, there are 148 quality measures. Now, not all physicians have to report on all 148. Some of them are state dependent, some of them are depending upon the insurance organization that you're contracted with. But the core subset of that was 98. So if you have, if you're trying to meet 98 different quality measures, and out of those 148, only 20 of them were outside of the clinical experience, and they're still, the data is only gathered at point of care, but only 20 of them were, like smoking status, exercise, which is a self-reported outcome. Like so only 20 of those out of 148, only 20 of those were things that would be kind of exobiome, social determinant type data elements. And it was fascinating to me. As a physician, I don't understand how your wife does it. I really don't. I think it's admirable that they try. The practice of medicine has become so much about data entry, and it's unfortunate. I think that the new regulatory environment, I think that MACRA is going to allow for the streamlining of some of these processes. So I think that MACRA and MIPS and that movement towards that kind of inevitable movement towards value-based care is going to perhaps address some of these death by EHR click issues that we're seeing in medicine, which will lend the way towards more innovative, more innovative care management, more innovative care delivery, more innovative encounters. But it's going to take a substantial amount of time and investment for us to get there. So our goal in surfacing social determinant data is trying to make sure that it is as seamlessly integrated into workflow as possible, and that it's not data points, that it's simply additional insights into this particular patient that would help you identify deviations in care plan and engagement that would be effective for this patient. But if you're just presenting more data and you're presenting more clicks that somebody has to do, or you're presenting yet another login to another website that they have to go to, I think that that's going to be highly ineffective and not very likely to be used.
So would it be fair to say that in trying to do that and understanding that we want to create a personalized interaction and personalized care plan for each individual, it would help to have some type of standardized groundwork to come from? Because as you said, with diabetes, there is over 100 different potential quality measures with, I think you said 90-something core. Why do we need that many? It seems like we should come down to a dozen at most, and then you can build off of there, and you build by personalizing.
Right. You would definitely think, and so I don't envy all of the organizations that have to that create the quality measures. And I'm not a clinician. I'm just a data geek, and so of course I love the fact that there's 148 different specific data points that I can take. But having shadowed clinicians and having trying my very hardest to understand all the challenges that they face in their day-to-day practice areas, and understanding what it is like for them, not just from a quality measure standpoint, but then having to spend all of this time after the fact dealing with prior authorization issues around procedures and around the drugs that are being prescribed in order to treat these conditions. I think that being able to reduce and optimize being able to identify what's truly meaningful, like what is truly going to help drive care, and what is going to what is helpful, what is a quality measure designed to do? Does quality really mean quality for the insurer to be able to trigger prior authorization processes? Is that what quality means? Are those quality measures in existence to recognize performance, provider performance, whether for a consumer-facing website where I'm looking at quality of surgical performance, for example, or hospital performance, or does it exist from a quality perspective of the quality of care that the patient receives and the outcomes, the clinical outcomes that are associated with that care? And I know that the quality measures, there are outcomes measures, there are process measures. I don't envy the entities that have to go through and try to standardize and optimize those measures, and I'm sure that there is a reason that there are so many, but I am also sure that there could be substantially less if we had the opportunity to redesign the system from the ground up. But that's not going to happen. That's a nice pie in the sky. That's a nice pie in the sky opportunity. But if Mandi ran the world.
Well, maybe that's a good way to question about disruption, because I think in listening to a lot of ideas that are out there, there is definitely a groundswell of wanting to create disruption. So maybe before we ask, how would you, if you ran the world, change the system? Is the system getting anything right as it is now?
I think that the system has competing forces, right? And so I think that there are definitely individuals. Healthcare is full of really brilliant, really passionate individuals who desperately want to make the world a better place for the patients that they serve, right? I mean, it really is, whether those people are physicians, clinicians, nurses, and then on our side, the health IT people, it is full of individuals who desperately want to do good in the world, and who really want to make a difference in people's health, period. Healthcare as an industry, and healthcare as, I think, the largest single industry contributor to the United States economy, right? So $3.5 trillion and growing every year. As an economy, we are dependent upon the waste that exists in the healthcare system. So true disruption of a multi-trillion-dollar industry is incredibly, I mean, it would be incredibly disruptive to our economy. Hundreds of thousands of people would have to be retrained in new jobs. if we were able to effectively address all of the issues that cause waste and all of the issues that cause harm and all of the fraud, then hundreds of thousands of people would effectively lose their jobs if we became more efficient. And so I think that we will see innovation and disruption happen in small pockets, and we will see it happen in both. I think it's going to be on both ends, the two ends of the spectrum. So I think that the people who can afford a significant amount of medical privilege are going to have an opportunity to take advantage of substantial digital disruption. But I also think that that same type of digital disruption could be applied to the most underserved, especially as we look at Medicaid, right, and what's potentially going to happen with Medicaid and the states that expanded Medicaid. I was just reading today that I think it was between 14 and 18 million people are in the states where Medicaid was expanded are going to lose coverage. So if we go to block grants or we go, however the Medicaid system is going to be modified, Medicaid as an institution is going to have to do a whole lot more with a whole lot less money, and the only way to do that is through innovation. And so I think that the same type of digital disruption that that many early adopters will be able to take advantage of on the high end of the spectrum is going to substantially help the underserved populations that desperately need help the most, because we won't have a choice. So desperation fuels a lot of innovation opportunity.
Yeah, no, I think that's a very interesting point. It's and kind of like, as you said, having pockets of innovation. Maybe that is an ideal way to go, because then you see success and then other people will adopt it, because it's it's almost kind of like the federal state example. The federal government can do large things, but the states are the incubators, and they can experiment. So if we can do the same, take that same type of concept in healthcare, hopefully that it's almost unconscious disruption, because you've got change and then people have just all of a sudden the system has shifted without you realizing it.
Yeah, it's interesting because I am speaking next week on the Node Health at the Node Health Forum at the HIMSS Connected Health event, and Node Health exists to accelerate digital health innovation into evidence, right? Because that being able to overcome, like what you just talked about, the pockets of innovation that happen. Healthcare as an industry is very unique, and one of the women who's on this panel is a VC. She's the CEO of a VC in New York, and she was explaining that her company invests both in healthcare as well as in financial industries, and the difference between the two for her is kind of astounding, and they're both heavily regulated, but where financial is very willing to accept innovation and to pilot at scale and to share a lot of information about the successes and failures. Like, they standardize very quickly, they share their learnings very quickly, so they are rapidly able to adopt new innovations at scale. But healthcare is so IP oriented, so everything about healthcare is very kind of strangled in the protection, like the publisher perish mentality that,
right.
that came up through academia is resident in healthcare, and that in conjunction with kind of the clinical, the IRBs, and all of the oversight processes makes it very tough to innovate at scale and to be able to share innovation. And so that Node Health organization has been formed to try to accelerate the sharing and the collaboration opportunities, so that startups like Aloha and others aren't strangled by death by pilot, constantly piloting and doing the same pilot again and again and again, and organizations where learnings from that pilot could easily be applied and full-scale programs put in place in other organizations. But the individual IRBs at each organization make that challenging, right? The individual processes that you have to go through within specific to the healthcare industry make it very challenging to be able to adopt innovation at scale in our industry. And I think that's a hurdle that we're looking to address, and it's something that will definitely need to take place in order for us to more fully take in, back to the social determinants of health, being able to more fully take in and understand how these non-health data elements can be applied in a rigidly controlled environment. Healthcare is used to we're used to CROs, like from a clinical trial perspective. We're used to very close controlled environments, and understanding all the ways that the big bad real world impacts our very sanitary space and our very sanitary regimens and protocols is challenging. It's going to be really tough. So that's one of the key problems that we need to solve as an industry in order for us to more effectively move forward and address all the challenges that the new administration and the likely changes to healthcare policy and healthcare delivery are going to bring.
Right, and I think that laying out of challenges is a kind of almost a call to action, and because I hate to have to say this, but I can't believe we're actually all out of time already. This has been a very free-flowing and fast conversation, so I really want to thank you so much for joining and for being a guest today.
Oh, it's been great. Thank you so much, Matt. I appreciate it. It's been wonderful.
Yeah, no, we'll definitely have to have you back as we keep, as the industry keeps changing, and hopefully some of the predictions or aspirations that we discussed have occurred. And here's your cat making a final appearance.
Here's Lucifer. He decided to chime in the last second here.
And thank you to everyone for listening. Keep the dialogue going and connect with me at #HCDEJURE. I'm Matt Fisher. Until next time.